Hi, I'm Dr. Donna Lane.
And I'm Dr. David Lane. And Dr. Team asked us to talk a bit about trauma and private practice. I know that a lot of people angle toward private practice when they get this counseling degree that you all are working toward, that you're pursuing. Um, I hope that you are called to do this because I feel like it is a calling to work with people, and because it's quite an honor, quite a privilege when somebody invites us into their life. They tell us their story, they talk about what's going on with them. Ideally, they share their deepest and darkest with us. So if we're not called to do that, then we probably ought to find something that's better suited to our indifference. Because I believe that with that kind of honoring that people do, with the trust that they establish with us, that they offer us just without cause, really, because they don't know us from Adam. They got our name off Psychology Today, or they found our picture on the internet somewhere, maybe read a little bit about us, but really don't know us from Adam. And they come in and they're ready to tell us their life story just because the profession kind of imbues us with this trust factor. And it's kind of an inalienable thing for counselors. People just kind of sort of automatically trust you. And that's something to take very, very seriously. But anyway, that's a whole nother topic for a whole nother day. But wanted to lay the base for talking about trauma and how it how it manifests itself in private practice by talking just a minute about private practice. A lot of people head in the direction of a private practice when they are seeking this degree. They want to be able to do a private practice when they're done, and that's a wonderful thing. Being self-employed is really, really good. Suits lots people's temperaments really well. The scheduling is nice. You get to kind of set your own hours. You get to kind of set your own pace. You get to decide, can I see 6, 8, 10 people a day, or do I want to just keep it to 3 or 4 people a day? You decide all of those factors. There are some problems, however, with private practice that a lot of people don't think about. We think that we are going to get our license, we're going to do this degree, we're going to get the supervision, we're going to do our license. And then once we get our full license, we're going to hang out our shingle and we're going to wait on the telephone to ring, and those clients are just going to pile up. I'll have to take a big stick and beat them off. It's going to be so many that are going to be clamoring at my door. And sadly, that's not the way that it works. A difficulty that a lot of people have when they go into private practice is that private practice requires a different kind of hat than our counseling hat. We have to take off our counseling hat and put on our business person's hat because we're running a small business. It's just the truth. And with like any small business, we have to have a plan, because they say in the military, um, prior planning prevents poor performance. It's 6 P's, but I only said 5 of them because I don't know how liberal I can be in the course. But if you're failing to plan, you're planning to fail is another thing they say in the military. So you have to make a business plan for your private practice. Then another thing that a lot of people don't do well, because our heart is pointed in this direction for counseling and business requires it to be going in this other direction, which is frequently counter to who we are as people and how we see ourselves as counselor, that we have to go do marketing. And marketing involves a lot of awkward, uncomfortable stuff that most of us just don't like. Most counselors are social introverts. They know how to be social, and they're okay, they're decent with people, but the way that they feel good and charge their batteries is just being quiet, maybe watching a movie, reading, having some time to themselves. That's how they recharge the batteries. So it's awkward and it's uncomfortable when I got to go out and I got to meet I got to go meet physicians, I got to meet psychologists, I got to meet other therapists, social workers, marriage and family therapists, etc., and establish networks for referrals. And the literature says that I need to shop within, I need to, that clients shop within 8 miles of where they live for a therapist, about a 15-minute drive, which in a urban or suburban area is about 15 minutes. So you then have to create in your part of your business plan and marketing plan to hit every other therapist, healthcare provider, medical worker, etc., within an 8-mile radius of where you plan to set up your office. If you're doing a virtual office, then the marketing is a little different, but you have to do marketing nonetheless. And so when you create that plan to hit everybody within 8-mile radius of where you're going to set up your office, you then put together marketing materials, business cards, maybe a one-page information sheet. They call it a slick in the marketing business, a slick sheet, because it's usually glossy looking, nice paper. And you got that one page slick, you got business cards, and you call every doctor's office, physician's office of every kind. You don't just call psychiatrists. No, nope. Because they see a lot of folks and they need folks to do talk therapy. So you do call them, but that's not all you call. Who is the largest provider of medication in the medical profession? Who writes the most prescriptions for psychotropic medication? That would be gynecologists and OBGYN. Second to them are family practitioners, because people come in, women in particular, postpartum with OBGYN. They come in, they are postpartum, they have depression, they're having struggles, they have transition, they have adjustment issues, and they need some talk therapy. But they start complaining to a physician about depression. What happens? The physician gives them a script. Doesn't matter what you go in complaining of. The doctor's job is to do something. That's what they're trained to do. Do something. And so they go and do something, which in their mind is give medication. So you have to think about all those. You got to hit dentists of all things. Why? Dentists are the first people to recognize eating disorders because of the enamel wear on the teeth from throwing up. And so if you hit dentists, you hit physical therapists, because with any kind of injury, there's an adjustment period, and frequently accompanying that is anxiety and depression. So you see how you need to be thinking, which is not how a counselor thinks typically. This is how a salesman thinks, which is a big deal in our lives, because it's often counter to who we are and what we do. Our heart is of service. Our heart is of mercy and compassion and provision and all of that kind of stuff. And you think about a salesman, they're trying to milk you for your last dime. And that's not who we are. That's not what we do. And so it's an interesting paradigm and a paradox sometimes for counselors to move into private practice. And I just wanted to plant a few seeds to have you think about some stuff that is not talked about in graduate school. I don't know a single anywhere, and McNeese may be different, but I don't know a single anywhere that offers a course in operating a small business and setting up a private practice. You might get a seminar on that in a course. You could go to a weekend something to learn how to do that. But I thought I would throw that in just to kick us off and get us talking about and thinking about private practice and the vagaries of it. Then there's the things that are kind of counterintuitive to us that we don't naturally do. Then there's other pieces of it, like you have to think through. You have to think through your overhead. If you're going to have an office space, that's going to cost you money. You're going to have a computer system of some description. Most people do electronic record keeping, which is an additional cost. So part of your business plan has to be a budget and figuring all of that out. And so there's lots of little things that go into planning a practice and executing a practice that we don't naturally think of. But if you do a good job marketing, you go meet the right people, you discipline yourself to go spend 20 hours a week, those first few weeks, making marketing calls where you're either calling on the phone or sending an email, or vice versa, sending an email, follow up with a phone call, then trying to schedule a visit with all of those other therapists and physicians and physical therapists and occupational, everybody within about an 8-mile radius of where you're going to set up your office, so that they can begin, so that you can begin establishing referral base among the physicians, et cetera, the other kind of providers. So just wanted to get you thinking about private practice. Then once you get the private practice up and running, and the phone does start ringing and people do start showing up at your door, and you find the right connection. Oh, an overlooked one just popped into my tiny little 6th grade educated brain. An overlooked one is churches. I have had 1,000, I'm a counselor educator, just like Dr. Team. I've had, gotta be 1,000 pastors over my 32-year counselor education career come to me and say, Dr. Lane, I really need to add on the counseling degree to my DMin or MDiv degree, because I went to school and I took all of the Paul's letters. I took the Gospels. I took the history of the early church. I took contemporary issues in the churches. I took Greek, I took Latin, I took Aramaic. I studied all that, and I got to my first job, and it was 85% counseling, and I ain't got a clue what I'm doing. So churches are always looking for somebody to counsel. So if you have an affiliation with a church, or you're interested in church, then that's a wonderful place to potentially get some referral resources, because the pastor, if particularly if it's a small church, say less than 1,500, because there's a tipping point at probably 1,500 or 2,000 where they may have somebody on staff to handle counseling needs, somebody trained in pastoral care and counseling. But under about 1,500, it's generally the pastor and one or two assistant or associate pastors, but they mostly do education, community service, and those kind of things. And rarely do they have folks who are trained in counseling, much less a counseling center. So you go to a church, and at any given time in the population, about 10% of the population are struggling with some kind of, I'm loath to use the term mental illness, but they're struggling with some kind of something, depression or anxiety or substance use. Is 10% across the population. So guess what the percentage is in church as well? Church is not full of healed people. Church you think about as a spiritual hospital. A lot of people, and I get tangential here, but I chase bunnies frequently. But a lot of people say, "Oh, I can't stay in church." Build a bunch of hypocrites. What do you expect to be in a church? It's not full of healed people. It's full of people who need to be healed and fulfilled. But anyway, whole nother subject for a whole nother day. But you go to that church, there's going to be about 10% of the population struggling with some kind of issue, a counseling kind of issue, and the pastor's looking for somebody that they can trust to send those referrals to, because he or she just won't know what to do with it. They can do a little bit of faith-based kind of stuff sometimes, but to do real in-depth talk kind of therapies, they are always looking for good people to refer to. But a lot of people don't think about churches as being a good potential referral resource. Anyhow, enough about private practice business-wise, enough about marketing business-wise. The point is to think through private practice. We have to think through all of those issues that are kind of counter to who we are. Got to go be salesmen. And I don't know many salesmen that are now counselors, and I don't know many counselors that then convert to being salesmen. But you kind of got to wear both of those hats to operate an effective private practice. So you've got your private practice set up, and the phone is ringing, and people are showing up at your door, and you are getting a good referral source from the physicians in your area, and from the churches around you, from the schools, et cetera. So you got this nice little clientele that you're building. You want to do a good job, because this person goes and tells two of their friends, who go and tell two of their friends, and the geometry goes from there. So you do get people calling. You need to be aware that a whole lot, in fact, I would venture to say the vast majority of what you're going to see has trauma at its base. And there's all kind of disorders, all kind of things that people struggle with that don't seem to, what's it got to do with trauma? They are using a substance. Well, it turns out that about 85-ish% of people who use substances have an underlying trauma history. What does depression have to do with? I don't get. Well, it turns out we're finding out more and more all the time that trauma undergirds a whole lot of mental health issues, a whole lot of problems that people have. Now, it manifests itself in 10,000 different ways, but at the core of it, if you look at the tree, you see these leaves are all the symptoms, but it comes down to this root of trauma that's undergirding and is underlying the development of all of these symptoms. Most behaviors, what would be considered pathological behaviors, other than organic illness, schizophrenia, is an organic illness. It's a wiring and chemical issue in the brain. A true bipolar disorder, and by the way, another aside, I was in a workshop about a week or 10 days ago, and there are three most common misdiagnosed illnesses. Number one was bipolar disorder, and it's misdiagnosed 67% of the time. Write that down. Let it sink in. 67% of the time, bipolar disorder is misdiagnosed. But a true bipolar disorder is a chemical, it's a biological basis. So, excluding the organic components like schizophrenia and true bipolar disorder, the vast majority of pathological behaviors are maladaptive attempts to meet a legitimate need. And so if you think about trauma and what happens during trauma, we experience pain. We have to develop ways of coping. A child who is abused, and the abuse starts at a very early age, they learn how to survive given their context, and they have to have these maladaptive ways of surviving, what you and I would consider maladaptive ways of surviving, to make it. And then they get to be 14 and 16 and 18 and 25, and they're away from home now, and the trauma is no longer occurring, but they still are stuck with those maladaptive coping resources that they learned when they were 4 years old and 6 years old. And so they're a 25-year-old, a 38-year-old out in the world operating with 4-year-old defense mechanisms and 4-year-old coping strategies. And so a great, huge percentage of what you'll see in private practices are people with traumatic histories, and it's coming out in 10,000 different maladaptive ways, symptomatic kind of ways, because the people are still struggling, as if the trauma is still ongoing, and the coping resources that they have are all the coping resources that they can come up with. Otherwise, they would do something different, but they're kind of stuck neurologically, developmentally, etc., in this pattern of X happens, I respond with Y, and if Y doesn't work, then I try Z, and that's what they know to do, and that's how they operate. Now that they've gotten to be an age of majority and they're no longer in the abusive situation, this stuff is creating problems for them now. It's not solving any problems. It's not aiding their survival. It's now in the way. And so our job becomes to help them unravel that and see how what's really going on is trauma-based or attachment-based. I would encourage you to go do some readings on attachment theory. And with that, lay the base in your brain with attachment theory, then progress to object relations theory, because both of those explain a whole lot about what trauma does during the developmental cycle, early childhood development, and how that becomes it manifests itself lifelong unless treated. If it's left untreated, it will rock on for the entirety of a person's life. And I've been hogging the microphone, and I'm sorry, because I know you've always, with that super-powered brain, I know that you've always got some wonderful things to say, and I don't mean to take up all the airspace.
Well, I thought it might be helpful to share. I conceptualize trauma in a very specific way, and I'm a visual learner, so I always talk in word pictures. So if you think about the person's personality structure when they're born, they have kind of a basic structure. And you think of trauma as like a hammer that taps on glass. So their structure is there, that's the glass, and the trauma will sometimes just barely tap, and maybe there'll be little cracks in the glass. Sometimes the trauma taps consistently over a long period of time, and the glass starts breaking. Bigger cracks get bigger, bigger, bigger. And sometimes that hammer is a and the glass pieces fall out and break off. And then you've got these shards of glass lying around inside this person's personality structure. So I think of it as, you know, if you think of the continuum of trauma, from very everybody has some types of trauma. That doesn't mean everybody has a trauma response, But things like grief can result in trauma. Different being in a car accident, knowing someone who was in a car accident. There's all sorts of that hammer just barely tapping against the glass. And if you do that enough, if you get that barely tapping enough, then the fractures start happening. So those little shards of glass are aspects of that person's personality. And the way it works, my view of trauma, is that those aspects of personality get very rigidly stuck in the place where they are. So wherever the glass broke, say they had a severe trauma experience as a child, pop, and the glass shatters or fragments, wherever that glass was in that moment, then that person in that part of themselves is stuck there. So hold that thought for a minute, and let me give you another word picture. We are born, if you think of ourselves as a house, we are born with a big, wide open house. And I've always said that my ideal place to live would be one of those loft apartments that used to be a warehouse, and it's just wide open. There's windows on all sides. You don't have walls. You've got, the kitchen against one wall. You've got minimalist furniture. You've got maybe a TV hanging on the wall, and that's it. Well, that's like my ideal place to live. And in my conceptualization, that's how we're all born. We are wide open. We don't have walls built up. We don't have rooms set apart from the other rooms. And as time goes on and trauma starts creeping into our lives, or painful experiences, suffering starts coming in, we start building up walls. We have this room over here that we protect with these walls or these defenses. And then we've got the living room where we let people come in. We'll let them in. Some people only make it through the entrance hall, but there are a number of people that make it in the living room. But nobody comes in the bedroom or very, very few people come in the bedroom because it's the bedroom. And the basement, forget it. Nobody's going in my basement. It's piled with junk. It's musty and gross and dirty. Ugh, no.
Which is where I live, by the way.
So those rooms start developing in us. And we pull from each one of those rooms to play different roles. So now back to the pieces of glass. So we've got this one piece of glass, that's that little kid that went through that initial trauma. Well, that piece of glass lives in the basement. That part of myself lives in the basement, alone, isolated, cut off. On occasion, something will come in the door that kind of opens that door to the basement, and that piece comes roaring out and makes all this noise and does things, as David said, does things that a 3 or 4-year-old would do, because that was the developmental stage that they were in when that glass broke. Then there's another piece of glass whose job is to guard the system. And so they stand in the entrance hall, and they are the ones that monitor who's coming in, who's getting out. Nothing gets past me. They act as a guard over the system. Then there's another piece of glass that acts in the role of the you would call it presenting person, or the person that interacts with life. And they try to present a very together, very, I've got this kind of persona, and it is a persona, something they've painted on the glass. basically, is a way to think of that. And they hold that up and they present that to people, and they get along pretty well until something opens that basement door, and then it's here comes the 4-year-old. And the 4-year-old expresses all the feelings of the system, all the feelings of the trauma, and does so in a way that's a 4-year-old way. So by definition, they don't know how to do it. They never learned how to do it. And because they're isolated in that basement and they don't come out and grow and develop and continue to interact, they're kept separate. Then they don't grow up. They don't learn from being out in the world and interacting with other people and learning by observation. They're just down there isolated. And so you think about the different rigid roles that the shattered pieces of the person play. And you think about them coming in the counseling office. So who's going to show up? You think the 4-year-old kid in the basement is going to show up? The answer to that is no, not right away. Certainly not. The persona, the painted glass, will show up and tell you superficial things and present with very what I would call content-related problems. I'm struggling with my boss at work, or I'm having difficulty managing my money, or my marriage is struggling with, we argue too much and we don't communicate very well. Okay, that's all valid. That's probably is going on, but that's on this level. And that has nothing to do with what's going on in the basement. Does that make sense? So your job as a counselor is twofold. The first job, and probably the hardest, is to get past all those walls, to get people out of those rooms, basically, if you want to call it people, the pieces of glass out of those rooms, and get them kind of engaged with life, engaged with you, interacting, talking about what's really going on in those dark, closed off places. The second job, which is also a difficult job, is helping the client pull those pieces of glass together to form a coherent story. So when the glass shatters, when all of the rooms start being developed, the trauma survivor's story fragments with those pieces of glass. And so the trauma story is kept in the basement. It's kept separate, and it's actually stored in a different part of the brain. So it is literally kept separate. Because it's kept separate, it has no context. There's no beginning, middle, and end to the story. There's no life around that experience. That experience is like this single moment in time. And when the door to the basement opens and that glass comes out, that single moment in time is the totality of that place in that person's experience. And their feelings are entangled with that experience without any context. So your job is to help the client integrate their story, pull all the pieces together, to be able to tell their story as a beginning, middle, and end, the way stories are supposed to be told, an overarching story of the whole. But for the trauma survivor, as long as they're broken up, like I'm describing, it's not a whole. They don't perceive it as a whole. It doesn't feel like a whole. It feels like I'm living in different places. I'm presenting different people. And I'm not talking about, I'm not describing dissociation. I'm just using this language to try to explain that that fragmentation is what goes on when they experience that trauma. So you want to develop ways to connect with in the different rooms, the different pieces of that person. You want to help them learn how to give voice to the feelings in those different places. And you want to teach them or work with them to develop the ability to tell their story as a whole. It matters how they tell the story to themselves. That basically our lives, in our perception, are the story we tell ourselves. So how we see it is based on the language that we use internally about it. The other thing that happens in trauma is, for each piece of glass, there are certain false beliefs that get attached to that place, to that room, or that piece of glass in that room. So really common false beliefs for trauma. Big one, it's all my fault. I should have done something. I caused it. That's a big one. Another one is that survivor's guilt, if you want to call it that. It should have been me that didn't survive, or I should have been the one punished, and a view of themselves that's debasing. So I'm unloved, I'm unwanted, I don't matter. And that I don't matter ends up being a really big one for trauma too, because if I mattered, they wouldn't have treated me that way. That's sort of how you develop that belief. I'm never going to be good enough. Those kinds of beliefs about myself, they get all attached in there with the deep places, the basement, the deep places in us. And those beliefs operate as the operating system. If you think in computer terms now, it's the operating system from which we perceive life. So I think of it as a pair of sunglasses that we wear. My sunglasses are colored with, I don't matter, I'm never going to be good enough. Then that looks brown. And so everything that I see when I've got those glasses on looks tinted brown. Everything I see becomes reinforcing of the false belief I already have. So it kind of feeds back in to what already is going on as a reinforcing system with this sort of internal language that says, see, I told you so. I knew that was true. It's a self-fulfilling prophecy. I knew I was true. I knew I wasn't good enough. I knew that I didn't matter to anyone. The two other big false beliefs that we end up kind of growing out of those perceptions of ourselves, these false beliefs tend to show up in the other rooms, is fear and shame. So fear is, what ifs, all the what if questions, the expectation that something bad is always going to happen. It's like there's an innocence that's lost through early trauma, where they learn their naivete when they're younger, that believe that everything was fine and nothing bad's ever going to happen. That gets shattered along with their personality structure. And now they're suspicious and they're hypervigilant and they're checking out everything and they're on their guard. So that's the guard I talked about, that guard that tests everything and checks everything and keeps everything at bay or at arm's length. So you've got the fear-based beliefs. Fear-based beliefs also evidence themselves in control. And it's kind of interesting. It's a two-sided coin where you feel out of control. So your response to feeling out of control is you try to control. And you try to control other people. You try to control circumstances. You take responsibility for things that are not yours, that really belong to other people. And you try to use your power to keep everything like you want it to be, so that the outcomes go like you want it to go.
And what percentage of people that we see as counselors have control issues?
Like
100%.
That's like big everywhere. So then after a while, when you're trying to control, it is very evident very quickly that you have no control, which then, if you're operating in the control system, flips you back over to feeling out of control. The more out of control you feel, the more you try to control. The more you try to control, the more out of control you feel, and on and on and on. So you just keep ping-ponging back and forth between and trying to deal with your fear. And this is all in response to fear. All of the control stuff is in response to fear. And that shows up in these, like I said, the outer rooms. The other one is shame. And I mentioned some of the shame beliefs before. I should have done something. Anytime you hear a should, that's a shame-based belief. I should have done something. It's my fault. Looking for blame or blaming others. It's you did that to me. And so again, it's like a two-sided coin. It goes back and forth. Shame, blame, shame, blame. I'm all bad on me. I'm terrible. It's my fault. And then I'm projecting that on you. It's terrible. You're terrible. It's your fault. And those three kind of systemic beliefs form a self-reinforcing system where like I said, the self-fulfilling prophecy about the color of my glasses. If I feel like I don't matter, then what am I going to see everywhere is that I don't matter, which then makes me feel what? Fearful, because I feel insecure and out of control, and it makes me feel ashamed. So those are the kinds of things that you will see in the counseling office. I would encourage you to learn to listen to people's language. Their language reveals what's going on. Even when they are not ready to let you in, the language will reveal what's going on. So again, if you hear shoulds, your mind needs to go, okay, that's shame. I know that they've got shame. If I can figure out where that shame is rooted and what it's based on, then I'll be able to help them uncover that and then bring that out into the light of day. If I hear have to or can't or what if, that's power language, that's control language.
Feeling trapped language.
Yeah. And ultimately, that's where anxiety and depression comes from, is feeling powerless and trapped. And so that language tells you they're operating in fear. It's really interesting to notice in your clients the percentage of people that make decisions based on fear. And what's the percentage?
100.
that driving force in their lives, that what is termed in trauma research as hypervigilance is kind of always operating. The inner hormones are stirring, the adrenals are pumping, and everything is always check every corner, watch everybody, because something bad's going to happen, is the foundational belief. So you want, in addition to helping them tell their story as a whole, you want to help them their story in truth, not based on these false beliefs, but being able to address those false beliefs and confront them and be able to come back with what is real and true about them, and then have them reauthor their story. This is starting to sound like narrative counseling. Have them reauthor their story with these new truths and as a whole.
And so all counseling starts with assessment. That's the first thing that you do. And so in your assessment, think about what Dr. Donna is saying, that I'm listening carefully to their language, and I'm looking for indicators of trauma. The light tapping or the heavy smashing, irrelevant. and I'm looking for traces of trauma. There are a couple of assessments that you can do. They're more formal assessments. A genogram is a very non-threatening way to get people to talk about trauma that's come down through the family lineage, generation after generation after generation. And it doesn't threaten me to talk about my granddaddy or to talk about my mama. That's not threatening. It's threatening to talk about me right out of the chute. So, and the second formal assessment that I would encourage all of you and think through, do, and learn about is it's called the ACEs, the Adverse Childhood Experiences Scale. It's a real simple scale. It's only, oh, my brain just, it fell out the bottom of my brain, 15 or 20 items. It's not really long. And it's highly reliable about the quality of a person's early childhood experiences and the life that they led while their personality was being formed. So the genogram and ACEs make a really good combination for assessing trauma. And so that's the first thing we do in counseling is assessment. Second thing we do is build rapport. So we are imbued, like I said a little bit earlier, we're imbued with kind of automatic trust. If we're a counselor, people, well, this is probably somebody I can try to talk to, and they'll let you in the front door and maybe into the living room. But then it's your job to create an environment in which you can build rapport and they can trust you to let you into the dining room and into the kitchen, the bedroom, and the basement ultimately. But that takes some time, and you have to be patient and know what you're doing. You know where you are. I'm still in the assessment and building rapport, building trust phase. You're constantly looking at where are we in the process. I got a complex trauma case that I'm 3 years and 4 months into, and this person trusts me, and this person has now begun the work of opening the basement door. That's all. We're not in the basement, but this person is at least opening the basement door 3 years, 4 months into treatment. And what I've done so far is build good trust and demonstrate clearly you are safe here and I'm not going to hurt you further. We got to go look at this mess in order to get this stuff out of your life. But I'm not going to inflict any more pain, and it's a safe place for us to go look at this mess. It takes a long time sometimes to build that rapport, even though they give us a little bit of automatic trust right out of the chute. It's still hard to get through those doors and get down into that nasty basement where all the junk and the clutter and the trash has accumulated for all this many years, and all those broken shards of glass are just scattered everywhere. And it's going to take some time to do that. So whatever you wind up practicing, two things have got to happen with every model that you have, whether you wind up psychodynamic or strictly behavioral or DBT or narrative or reality therapy or cognitive ad infinitum. You do assessment and you build rapport and establish trust. Those are the first two things that you do. And you kind of go in, the research is saying more and more every day that a large degree of the problems that counselors would see versus need medical attention or grow out of trauma and the effects of trauma. So do a good, thorough assessment of your trauma using some formalized trauma assessment kind of things, using some informal things like listening carefully to their language, shaming language, trapping language, fearful language, so that you can get a good handle on what's going on with the person. And once you form that picture in your mind of what's really going on, then you can help lead them to what they need to understand. And it's going to show its head in many, many different ways in a private practice. Doesn't matter the symptomatology that people are talking about and putting in front of you. Think first trauma. And there may be a unicorn out there who doesn't have some trauma in their background that's driving the symptomatology that they're having. But far and away, the majority of people have a history of trauma of some description, and that's what is disrupting and creating so much disruption in their life to this day. So I hope that's been beneficial. Dr. Team, let me know if this was helpful to the class and if the class got something out of it. I hope they did. Also, class, you need to know how proud we are of Dr. Team. She is a real model for our counseling program at Mercer University. She overcame tremendous obstacles to be where she's standing right now at the front of that room. And I want you to know how proud we are of her. So hope it's beneficial. Hope this has been a good thing for you. Dr. Team, let me know if you got any questions. And Lord willing, we'll see you soon.
Bye.